All right, good morning, everyone. Thank you for joining us, those of you who are online and those of you who are in person especially. Today we have the honor of hearing from Dr. Marie Faughnan. For some of the junior trainees here who may not be familiar with her work, in addition to general respirology, she's a world-renowned expert, maybe the world-renowned expert on HHT, which is a more common condition than people may realize, and is a very important one with lots of potential ways things can go wrong for those patients. Despite the previous low profile of this condition, she started a clinic, the first of its kind in Canada, and by far the best to manage these patients. And she's very protective of her patients. She makes sure that they have a complete comprehensive plan before she's willing to let release them back to their referring physicians again. But it's with good reason. The care that she provides is exemplary. She's very passionate about the care of each and every one of her patients. Of late, she was in the news a lot for donating half of her liver to a colleague, and that I think should not overshadow what she has accomplished professionally. She was the first author of the first guidelines for hereditary hemorrhagic telangiectasia, the international guidelines on the subject. And she's been a pioneer in the area. She works in Toronto, but she's been kind enough to come to see us today. So everybody, please enjoy.
Thanks so much for that super kind introduction, Marcel. It's really a pleasure to be here. And I'm just going to make sure I've got everything sorted here. I think it's probably better for me to use the pointer, the cursor than the laser pointer, because we have some people online, if I understand correctly. Okay, great. Well, welcome everybody, and I really appreciate the opportunity to come here and speak to all of you about pulmonary AVMs, HHT, and new therapies in HHT. And so I've always been a bit of a nervous speaker. I never say no to talk about HHT because, as Marcel said, I'm very passionate about this. So I'm really excited to be here and have the opportunity to share both some information about and an update on the current standards of care in lung AVM care and HHT care, but also some insights into what's coming next, because there's a lot happening in the world of HHT. So. Okay, let's make sure. There we go. Thank you. This slide actually, with my disclosures, actually has really dramatically changed in the last 5 years. And I think that's a little bit an example of how things are changing in the HHT world. It used to be really easy. I would just say, there's nothing, we have no treatments, there's nothing anyone could consider that could be a conflict. And it's really actually changing in the sense, I don't mean with my conflicts, but I just mean that there are a lot more people interested in HHT now, and there's drug development happening, and we're being asked as HHT experts to be consultants and to be on advisory boards, and I've also had in recent years research grants funded by both the NIH and the U.S. Department of Defense for clinical trials in HHT. So this is a huge shift for me and for other people in the field. Am I okay with the mic? Okay, perfect. So the objectives of today's talk, as I've already alluded to a little bit, are first to review the preventative approach to managing lung AVMs. I realize that this is the most relevant piece for this audience, but given that 80% of people with lung AVMs have HHT, it's obviously a critical piece for respirologists to understand how to diagnose HHT, when to consider HHT, and what might be the implications for their patients. And as I said, I'll finish by talking about sort of the shift in the paradigm of HHT care with mechanism-based therapies that are in development and appearing in practice now too. So first, I'll talk about pulmonary AVMs, their diagnosis and management, and then more about HHT and treatment. So to start with the very clear definition of the pulmonary AVM, so that we're all starting from the same place. I mean, a pulmonary AVM is a direct connection between an artery and a vein, with a feeding artery, an aneurysm, and a draining vein. And most AVMs, most pulmonary AVMs look like this, where some AVMs in other organs tend to be more of like a nidus type structure like you see at the bottom here. And sometimes we see that in lung AVMs, but the lion's share of them are really like the simple fistulous type AVMs. And sometimes there might be more than one feeding artery to it, but it typically is a simple lesion like this. And obviously the important piece here is that when you have a direct connection between the artery and the vein, there's no capillary network in between. And this is really, not only do pulmonary AVMs put people at risk of complications such as hemorrhage because their structure is less stable than the normal structure, but the lack of capillary network is really one of the important features that predisposes people to lung AVMs to neurologic complications such as stroke and brain abscess. Here's an example of a CT where, okay, are we good? Okay, here's an example of a cut from a CT chest where you might start with this and say, oh, there's a pulmonary nodule here, and what's going to make me think that this is a lung AVM are going to be some of the other images around this, and where we can really see that there are a number of vessels associated with the structure, that it's lobulated, smooth, and that there are connections with the venous system and the arterial system. So this is a pretty typical looking CT for a lung AVM. The clinical presentations of lung AVMs are a real mixed bag for me and for each of you, I think, in 2025. And it's sort of an evolving, it's been interesting to see this evolve over time during my practice. When I first started looking after patients with lung AVMs and HHT, we mostly were seeing people that were presenting with an acute complication. Our first patients had all had strokes or brain abscess or massive hemorrhage, and that's how they came to know that they had a lung AVM. Even though many of them had HHT, most of them didn't know they had HHT. But over time, other, I think, the other sort of typical presentations such as cyanosis, clubbing, and exertional dyspnea were rare then and continue to be rare now, but are sort of the classics that we learn about as in respirology. But in fact, now I would say that the most typical presentation that I see is basically someone who comes in with imaging done for another reason. And so like that first scan I've showed you, a lot of our patients who are referred to us now in the last few years are referred to us because they have a lung AVM on imaging. And so actually it's many of my respirology colleagues really that are referring new lung AVM patients to us. And those patients come to them often for imaging for another reason, a cough or chest pain, or some of this mixed bag of, either having had a complication of a lung AVM or perhaps having unexplained dyspnea, or like the patient that I just showed you actually had, he actually had imaging done because he had been noted to be hypoxemic on a pulse oximeter. I'll come back to that in a sec. Once we suspect someone has a lung AVM, the next really key step, so from going from that image that looks like a lung AVM, how do we know that it's a lung AVM and not like a venous varicosity, which is something I've seen more of over recent years, or other type of dilated vessel that's not a shunting, not a shunting vessel. And usually the typical next step is to demonstrate right to left shunt using contrast echocardiography or bubble echo, a few different names for it, but essentially it's a standard transthoracic echo with an antecubital IV in and an injection of agitated saline. So the agitated saline provides the contrast, and after you inject it, you see it here on the right side of the heart. And then after, and then in someone who does not have a right to left shunt, the next image should look the same pretty much. There should be the next, over the coming cardiac cycles, up to 10 cardiac cycles easily that we would be watching. There should be no bubbles appearing on the left side. But in someone with a lung AVM, like the one I just showed you, we can actually see quite marked appearance of bubbles on the left side. So this is not a difficult diagnosis on bubble echo to make, and it was not a difficult diagnosis on CT. Easy to show at rounds, but not the biggest AVM we've seen, but not a subtle one either. The reason we use bubble echo and that and I'll talk to you a little bit later about it in the context of HHT, is it's actually very sensitive at picking up even tiny lung AVMs. But this one, as I said, was easily picked up. We also did an oxygen shunt test, but we use these really more as a baseline before treatment rather than a screening test. And in this case, this patient's PaO2 in room air was 63 millimeters of mercury. And on 100% oxygen, it went all the way up to only 97 millimeters of mercury. And I know that people don't routinely use oxygen shunt tests in practice. We do because we see so many patients with lung AVMs, but we would expect it to be well into the 500s, even in real life oxygen shunt test. In the textbooks, in the 600s, but even in real life, it should be well into 500 millimeters of mercury. But this patient only went up to 97 millimeters of mercury on 100% oxygen, and the estimated shunt was 25%. Now, again, I was saying we use bubble echo typically to demonstrate right to left shunt when we see a lesion on the CT, and we want to confirm that it's a shunting lesion. The sensitivity of bubble echo, and I take these numbers from HHT, given that that's where most of the work has been done. The sensitivity of bubble echo is 97%. The sensitivity of the shunt test, about 65%. When we take all comers of all sizes of lung AVMs, and that sensitivity is for detecting a lung AVM that would require treatment. In other words, 3 millimeters or bigger, so a pretty small thing. So coming back to our patient whose CT I showed you, and I've actually combined information from a couple of cases just to maintain an anonymity. So he was a 40-year-old man who did not have a history of shortness of breath, even after the fact. He did not have any signs, did not have any cyanosis or clubbing. He was hypoxemic. He'd actually been referred appropriately for a sleep study and did have sleep apnea, but was found to be hypoxemic out of keeping with his sleep apnea and during the day as well on his pulmonary function tests. And so he was sent for a CT. So this is not quite imaging done for another reason. It's imaging done quite appropriately to work up his hypoxemia. And that's how his lung AVM was detected. But in fact, this gentleman had had a stroke at the age of 25, and he had some vascular risk factors, and it was attributed to those. But in fact, it was probably his most important risk factor was the lung AVM. He was not known to have HHT. This is I like it sometimes when one picture says it all. This is just one image from his pulmonary angiogram. And what I like about this, even though it's a little fuzzy because it was a motion artifact, is that you can see a couple of things. So this is a catheter pulmonary angiogram, which we do not for diagnosis, but for treatment. Okay, so once we've said, okay, we know this person has a lung AVM, and then we're embarking on a treatment plan, then we plan a catheter pulmonary angiogram at the same time as embolization. So, so the first step is the angiogram, and here's the catheter in the right pulmonary artery, and you can see that there are, first of all, this is a normal area over here with nicely branching small arteries peripherally, and then we have this large vascular lesion here with a couple of arteries leading into it. But most interestingly, on this arterial injection, and you can see kind of what the phase is like over here, you can see that there's filling of the pulmonary vein. Like that's how massive and quick the shunt is in this AVM. And so from here, once we've done the angiogram, then the goal is to embolize the feeding arteries to this lesion, and the feeding arteries to embolize any AVMs with a feeding artery of 3 millimeters in diameter or more. And sometimes we embolize them smaller than that too, but clearly the 3 or more should be treated. And so this is again, one picture shows it all, I think, a post-embolization image in the same patient where, oh good, I think it projects okay. So you can see embolization material in 2 feeding arteries. So he had 2 feeding arteries to this AVM. And this is, again, an injection in the artery just proximal to the coils, and you can see no opacification now of the aneurysm or draining vein. So this is a very good immediate result post-embolization. This is what we're trying to accomplish. So this is why when a patient like this gets embolized who had an estimated shunt of 25%, then immediately after the procedure, he has normal oxygenation and just his estimated shunt, though we don't do it immediately after the procedure, but at a month after embolization was 5%, which is well within our ROC, our own ROC curve limit of normal. So we've done our ROC curves for oxygen shunt tests, et cetera, and it's 8% for normal for us. So this guy went from, you know, a lifetime of hypoxemia to having completely normal oxygenation, you know, just with this one procedure. So a very satisfying result. But the real reason we do this, I mean, he was, as I told you, he wasn't short of breath. He wasn't complaining of his hypoxemia, but he had already demonstrated that he could have a serious complication from this. And we know that he would be, if untreated, he would continue to be at risk for stroke, brain abscess, and massive bleeding from this AVM. So this is the real reason in most of our lung AVM patients to treat is for prevention. This is actually his X-ray, and I hope this projects okay. It's just to give you an idea. This is his chest X-ray pre-embo, the PA and the lateral, and then 1 day post, and this is 2 months post. And, you know, it's not actually very easy to see the AVM on the X-ray. It often helps to have the embolization coils in to see. So I like to look at X-rays backwards if I'm showing residents so that I don't make a mistake and point at the wrong opacity. But if you look here, this is the one that helps. If you look on the lateral here, you can see the aneurysm quite clearly between the two feeding artery, the embolization material for the two feeding arteries. And if you look back, you could see it there. It's just a little bit harder to be certain of overlying the spine, et cetera. But the real point here is to show you that after 2 months, it's already harder to see it. In fact, I'm not really sure I can see it anymore. And this is exactly what we expect to see. So, you know, early on, we expect the oxygenation to normalize as it did. And we expect that the AVM, that the parts of the AVM that are distal to the embolization material, that they will shrink down over time. So the aneurysm, draining vein should shrink down. And it really probably typically takes 6 to 12 months for that full involution of the AVM to happen. But we like to get we like to see some early signs of it at the 1 or 2 month follow-up with both the oxygenation and the chest X-ray. So this patient, I always like to show, you know, more recent patients and not the same old favorites when I give rounds. So I wanted you to see his case, but he hasn't done his 1 year post-embolization yet. He's still, he's not quite 1 year out from embolization, but we were happy at 1 month to see this change on the chest X-ray and the normalization of the oxygenation. So quite comfortable then to wait for 1 year post-embolization and do a low-risk CT, like we do our follow-ups with non-contrast, low-dose CT, because we're doing prevention. So we're trying to make our screening and follow-up, et cetera, as absolutely low risk as we can. So when we have reassuring data like this at the 1 month follow-up, then we're quite comfortable waiting. Rather than, for example, there's a full range of what we could do. We could repeat a pulmonary angiogram to make sure it's fully occluded. But since we know that this is a very highly successful technique and we have all these good early indicators, we're happy to wait for the low-dose CT. So this is a different patient, just because I did want to show you what involution on the CT. This is a different patient where you see some representative images of her left lower lobe pulmonary AVM. And this is at 1 year post-embolization. And this is actually the embolization plug. But so you see that initially, but when you compare image to image here, you can see that the aneurysm and draining vein have essentially disappeared. There's just a little scar left there. So this is a good result post-embolization at 1 year. So embolization that I've been talking about can be typically done with coils or implants or plugs, and some of the devices and catheters, they keep evolving and changing, but essentially the procedure has been essentially the same since I've been doing this. I don't do the embolization. I didn't mean to imply that, but I mean, since I've been looking after patients with lung AVMs and HHT and working closely with interventional radiologists who do the embolizations, the broad strokes of the procedure have been essentially the same. And I take that as good because it's a highly successful procedure with good short and long-term results, both in terms of oxygenation improvement in most patients and prevention of complications, most importantly. There is a 10% reperfusion rate. And so we follow these patients for life. You know, so I always say to patients, well, we're going to get to know each other. And I'll tell you a little bit about the specifics of the follow-up protocol in a sec. But the actual procedure was first, described a number of years ago, and there have been lots of series since. I haven't put new series in because the information has been essentially kind of plateaued and stabled for like the last 15 years on this. And in fact, that's why we were able to make a very clear recommendation in the first international guidelines for preventative embolization of pulmonary AVMs. It's a low risk procedure, but I say that saying, you know, qualifying with when done by an experienced radiologist. There's no good data comparing inexperienced and very experienced radiologists at doing this, but you know, our interventional radiologist has been embolizing AVMs in 2 patients per week for 28 years. Well, we've had 2 in that time, but still, whereas most radiologists, I think, you know, might see 1 or 2 patients a year or every 5 years that they, you know, so it's a pretty big difference in experience. So, you know, the experience that is published are from radiologists who have a lot of experience. And in those hands, most common complication is a minor one, just a transient chest pain, which we manage with non-steroidal anti-inflammatories. But there is the potential for the more serious complication is paradoxical embolization of the device. So this is where I think it's really important to have the experience of the radiologist because they know how to minimize the risk of a coil or plug going through an AVM and going elsewhere, and know how to manage it if it happens. So there is a reported 1% risk of this happening. And despite that, you know, we've been, as I said, I've told you how often we do this procedure. I mean, we've had some patients have paradoxical embolization, albeit rarely over the years, but we've never had a long-term complication of the procedure. So I tell you that because though it sounds scary, this is like the way I describe it to patients, though it sounds scary about the paradoxical embolization piece, it is a very low risk procedure and the experience supports that. So just to summarize pulmonary AVM treatment, I keep checking the time because sometimes I get talking, so hopefully I'm on track. Embolization is considered the first line treatment for pulmonary AVMs. It's a low risk, effective treatment. Surgery is rarely necessary. I would never say never about anything, but it's almost never necessary. And we've never had to convert, I said I wouldn't say never, we have not had to convert an embolization procedure to surgery. But over the years, we've had a couple of difficult cases where we did eventually decide to resect an AVM, like sort of 3 or 4 times in 20, actually it's almost 30 years that we've been doing this. Sounds crazy. So very, very rarely do we need it. And it's not size dependent. Like people used to ask, you know, is there an AVM that's too big for embolization? No, there isn't. You know, so, and then for all patients, once we've embolized their lung AVMs, the follow-up is very important for reasons I've already mentioned, but it's also very important that they follow what we call pulmonary AVM precautions. So most importantly, antibiotic prophylaxis for bacteremic procedures to prevent brain abscess. And you know, if you look at a series of people with lung AVMs before they're treated, 10% have had a brain abscess. So even though we lack a lot of prospective evidence in this regard, it's pretty dramatic what the historical risk of brain abscess is. Secondly, we do, and that first one is the most important precaution. Secondly, we do recommend, when feasible, for people to have an air filter and a bubble trap if they have IV access to try and avoid any large air bubbles paradoxically embolizing through an AVM and causing TIA, for example. And again, but that's a very cautious precaution, but we do it when we can for elective procedures, et cetera. But there are lots of situations where people can't have an air filter, such as getting a IV contrast through a rapid injector for a CT if needed for another reason. Finally, we recommend all of our patients avoid scuba diving. And I'm happy to talk about that later, but I could do a whole talk about that. I love talking about scuba diving. So post-embolization, what do? 1 to 2 months, I told you we do a chest X-ray, oxygen shunt test. At a year, we do a non-contrast low-dose CT chest, and we're looking for involution of the aneurysm and draining vein. And every 3 years after that, we follow again with non-contrast low-dose CT chest, and we're looking for reperfusion. So in other words, an aneurysm or draining vein that starts getting bigger again. And often these patients have other small AVMs that have not been treated, so we're monitoring those at the same time to see if they've grown, which sometimes happens over, typically slowly if it's going to happen, but to see if they've grown to a size that needs treatment. And then finally, and really critically, once we've addressed this priority of treating the AVM and preventing serious complications, we need to ask the question whether somebody might have HHT, given that 80% of people with lung AVMs have HHT. And so I'm going to spend a couple of minutes talking about HHT. And then I'm going to talk a little bit about the HHT guidelines, because given that 80% of people with lung AVMs have HHT, most of our information about how to manage lung AVMs comes from HHT patients. So, it seems a bit funny that I'm always talking about HHT guidelines for lung AVMs, but that's why. I mean, they're very closely connected. So HHT is an autosomal dominant disease, probably about 1 in 5,000 prevalence. We used to think it was rarer. And it's characterized by vascular malformations. And the small ones are the telangiectasia, like you see here. These are, again, kind of like the CT was an obvious one to show in rounds. These are obvious telangiectasia. The patient that I just showed you the CT on, he had 1 telangiectasia on the side of his tongue. Nothing that was as easy to find as this. But these are some typical findings of HHT, and also characterized by organ AVMs, lung AVMs, but also liver, GI, and brain AVMs are kind of the most typical. And so not only do 80% of people with lung AVMs have HHT, but when somebody has HHT, they have a 40% risk of having significant lung AVMs that need treatment. So so these two things are very intertwined. When patients come to see me in clinic for a pulmonary AVM, I say, you're here for, this is a 2-for-1 deal. We're going to assess you for your lung AVM and for HHT, because I think it's really important to leave no stone unturned in that case. This is a picture of the international HHT guidelines from the second international HHT guidelines, which I'm very proud that we as Canadians ran this, this process once again. 15 countries, published in the Annals of Internal Medicine in 2020. And we really we continued to address all aspects of HHT in the guidelines that we had sort of started in the first guidelines, where we focused on lung and brain AVMs, and in the second guidelines, we added considerably more detail about some of the specific situations where we treat or where we manage people with lung AVMs, and also other aspects of HHT. So first thing, from the guidelines that I just want to summarize is just the diagnosis of HHT. So we still have both clinical and genetic diagnosis of HHT, and the clinical diagnosis is really like the first step. It's how we diagnose the index case. So because we know the operating characteristics of genetic testing for HHT in the context of a suspected HHT diagnosis. And there's still a lot to be defined in terms of when we look at variants of the different genes in HHT. There's still a number of these variants that remain. It remains unclear whether they're pathogenic or simply polymorphism. So there's still some uncertainty in the genetic diagnosis of HHT for sure. And we still rely on the clinical diagnosis for the index case. And the clinical diagnosis was first, which we call the Curacao criteria for clinical diagnosis, was first published in 2000, and we upheld it in both international HHT guidelines processes. So this is still the recommended criteria. These are still the recommended criteria for clinical diagnosis of HHT. So basically 4 items: recurrent nosebleeds, multiple typical telangiectasia in typical places, and organ AVMs, and a family history, either in a first-degree relative or a typical pattern of symptoms in the family. If someone has 3 of these criteria, that's considered a definite clinical diagnosis. And that's very helpful when you have that confirmed index case, but someone who is 20 years old and has HHT might only have 1 of these criteria. So the expression of the disease is age-related, and the Curacao criteria are not good for ruling out disease. but simply mostly meant to be useful for ruling in disease, particularly in the index case. And then once we have our index case in a family, then we'll go on to genetic testing to help us sort out the relatives. So we find the pathogenic mutation in that person in the index case, hopefully. We're able to identify now in 80 to 90% of families with HHT, we're able to identify their mutation. And then we use that mutation to sort out other people in the family. So 80% of families, 80% at least now, have a mutation in either the endoglin or the ACVRL1 gene. So those are the common genes for HHT, but each family has their own private mutation. So that's what we're saying is sort of the key is figuring out what that family's mutation is and then using it in the relatives. And then 3% have SMAD4 mutation, which is typically an overlap with juvenile polyposis. It's a rare subset of people with HHT, but one that's been well described and that we do see that basically have both diseases with SMAD4 mutation. So the indication for genetic testing HHT from the guidelines and truly this is how we use it in clinical practice is to rule in or rule out the disease in the typically asymptomatic relatives. So coming back to our patient with the lung AVM, he did have nosebleeds approximately twice per month since the age of 20, but they'd never been severe and he hadn't consulted for them. He had just one telangiectasia on the tongue. There was no known HHT in the family, but the family history was actually kind of suggestive with epistaxis in his father and a brain abscess in the grandmother. And we ended up confirming an endoglin mutation in his case, and other family members are being diagnosed clinically and assessed now as well. So often when we see someone with who we think of HHT, it's interesting, they'll often tell us about their kids. Well, my kids have nosebleeds, and we sort of say, well, that may or may not be HHT since nosebleeds are really common in kids, but what about your parents? You know, so it's like looking to the older generations often gives us that possibility of clinically confirming the disease. So I put this back up to remind me to loop back to the guidelines to tell you that, as I mentioned before, we addressed all aspects of HHT or all priority aspects of HHT in the guidelines, and we have actually 56 current HHT guidelines recommendations. And if I'd been invited to talk for longer, I would go through all of them, but I promise you I won't. But to show you that we did the lung AVM recommendations were actually all in the first HHT guidelines and upheld for the second. Though in the second guidelines, we developed recommendations for HHT, for children with HHT, and also management of HHT during pregnancy, and some of those relate to lung AVM. So I'll briefly touch on those. So, sorry, just before as I mentioned, and I think we could skip through this quickly now because we've really talked about it. The guidelines for treating pulmonary AVMs in general really come from the HHT guidelines, the most common cause of pulmonary AVMs. And basically the guidelines are screen HHT patients for lung AVMs with contrast echo, treat lung AVMs preventatively, and follow people with lung AVMs long-term. So repetition, but it's the most important thing I'm saying today. Pulmonary AVMs in children. I'm going to use a couple of these little topics to highlight some of our colleagues, some of our respirology colleagues who've really been very dedicated also to HHT and have moved the field forward. And one of them is Felix Ratchen, who runs the pediatric HHT clinic at Sick Kids. And he's done a lot of this work that is basically, to summarize it, shown that the prevalence of lung AVMs in kids is similar to adults, and that they can have the same complications of lung AVMs, albeit the risk, the prospective risk in a child may be lower, the yearly risk. But they are at risk of the same type of serious complications, and they have the same good outcomes from embolization. The screening tests also operate similarly, and embolization is not only effective, but equally low risk in kids. So that from the guidelines, the recommendations, the international recommendations were to screen for pulmonary AVMs in kids with HHT and to repeat that screening every 5 years because pulmonary AVMs seem to grow faster during childhood. But still a slow growth process in general, and that to treat preventatively, though this remains a bit of a more controversial area, is do you treat every lung AVM preventatively in kids? Or what's clear, what we were able to achieve consensus on in the guidelines is that you should for sure treat large pulmonary AVMs and pulmonary AVMs associated with hypoxemia. And otherwise, it's a bit of a judgment call about when to treat the children. At the pediatric HHT center at Sick Kids, Dr. Ratchin and his team treat most pulmonary AVMs. Second one that I just wanted to highlight was pulmonary AVMs in pregnancy, and wanted to highlight Dr. Els de Gussum, who runs the Winnipeg HHT Center, another famous Canadian respirologist in the HHT world. She has done a lot of the work related to, and a lovely person. She's done a lot of the work related to pregnancy and HHT and lung AVMs. And bottom line here, I'm actually going to skip a little bit quickly over this because I have gotten talking. But bottom line here is that patients with HHT should be screened for lung AVMs ideally before pregnancy. But if they haven't been, then they should be screened in early second trimester. And if need be, they can have low dose non-contrast CT chest. If a contrast echo, if they have a positive contrast echo in early T2, and if they have significant lung AVMs in pregnancy, we will treat them preventatively in early second trimester because there's a risk of life-threatening complications. It seems to be higher during pregnancy than outside of pregnancy, and it doesn't seem to be, there are no warning symptoms. So patients tend to die of massive hemorrhage without having minor hemoptysis or hemorrhage or symptoms before. However, if we know someone has HHT, have screened them for lung AVMs, treated them ahead of pregnancy, and all of that is in order, then they do not need to be considered high risk for pregnancy and delivery. But the untreated or unknown is the real concern. I want to spend a moment talking about a very severe form of lung AVMs, which is diffuse lung AVMs. It's a rare subset, about 5% of patients with lung AVMs, but very challenging to treat. And I don't have any good answers at this point, except that we, since actually I've got Bob Hyland's picture here, which some of you will recognize. He was my mentor, and we wrote this and he still is my mentor. And we wrote this. This was the first paper that we wrote about HHT in 2000, and it was about the patients with diffuse lung AVMs. And these patients, they have like this image here. Pretty much every vessel ends with an AVM, and they're profoundly hypoxemic patients. And you can't embolize all their AVMs like this. If we look at this image up here, this patient had a big AVM here. We embolized that for preventative reasons, but it didn't change anything about his oxygenation. So yes, we prevented some complications. We aimed to. But when we looked at the series, and we published, there are only 2 series published of these patients, 15 and 26 patients total. These patients are young and had a significant mortality at 5 to 8 years. And we don't really know how to, and they mostly die of pulmonary hemorrhage from those small lesions, and we don't really have a good way to manage them at this point. There have been a few patients who've had a lung transplant for diffuse lung AVMs, very small numbers. Again, this is a rare subset, but you as respirologists might see these patients, and these are our trickiest ones to manage. So a rare subset of patients, a rare number of them around the world have had a lung transplant, but very hard to know when to transplant them, because it's not like their oxygenation gets worse and then you say, okay, now it's time, or they don't fit in the box of our other patients that, or they don't meet any of the criteria that our other patients might for lung transplant, and there's so little experience. I put Scott Ackerley's photo here because he was recently advocating for a patient out in Vancouver at the Vancouver HHT Center, which he runs, and he very effectively advocated for a young woman with diffuse lung AVMs to get transplanted, and she's done very well so far. And so these are, in fact, I've introduced you to almost all of the HHT Center directors in Canada now. Now, just a few last words about evolving therapies in HHT. So I've really focused on lung AVMs, but now I'm going to talk about HHT in general when I talk about therapies. Interestingly, like lung AVMs are the part of HHT that we have the best treatment for, right? As it stands currently, as it stood in the first HHT guidelines and in the second. But in the last few years, we've started to have more and more information about the mechanisms in HHT. And this is now leading to mechanism-based therapies. And I want to talk to you about some of those, but they will not be, you won't see anything further about lung AVMs as I talk about these therapies, because that might be the last thing we end up treating with some of these new therapies. We have instead really urgent needs for treating chronic bleeding and HHT, chronic nose and GI bleeding, and also patients who have liver vascular malformations with cardiomyopathy. In addition, it may be those people with small lesions, like the small lesions in HHT, like the ones, the telangiectasia I showed you, maybe those are the ones we can treat most effectively with these novel therapies. So I'm a clinician, and I put this slide up with great humility, but I will try to explain in my own simple terms what I think the important pieces are about this mechanistic model. That then this is a 2022 version of it. It's been changing a lot, like every year in the last 10 years, really. But I think this diagram, this figure from Arthur and Roman in 2022, it gives you a good idea of what we're looking at in terms of mechanism-based therapy. So let me start by showing you on this picture, endoglin and ALK1 or ACVRL1. These are where most of the mutations are in HHT, and this is an endothelial cell here. And those are molecules on this cell surface, so the endothelial cell, receptors or transmembrane proteins, co-receptors, et cetera. The ligand for them, for both of them, is BMP910. And when we first learned about HHT, all we knew was endoglin mutation, ALK1 mutation. We knew it was kind of part of the TGF-beta pathway. We later learned that SMAD4 was the mutation for the overlap syndrome, and that whole pathway, that all fit in one pathway. And we're like, okay, this makes sense, but how? Like, how does this cause AVMs, and how does it cause it in one vessel and not the next one beside it? You know? When every cell in a person with HHT has one allele, which is mutated in one of these genes. So what we first learned was, you know, okay, this is where the mutations were. This is the pathway that was important. But then what we eventually learned is that in this disease of vascular malformations and increased angiogenesis or dysangiogenesis, we learned that the VEGF pathway was abnormal as well. And that we learned partly through clinical experience first, and then going to the mouse models, and then back to the clinical, back to patients, that anti-VEGF treatment was helpful, and it is helpful in HHT. It reduces bleeding in HHT, and the thinking is that the link, this whole endoglin, ALK1, BMP9, SMAD4, et cetera, pathway, when this pathway is reduced by endoglin or ALK1 mutation, that allows the VEGF angiogenesis pathway to function without its usual controls. So it allows increased increased angiogenic, but basically there's increased angiogenic potential in the endothelial cell because the brakes are off. Okay, and so that's kind of probably the most important piece. And then the second most important piece that's come out in recent years is that if you just have one mutation in one allele, it's probably not enough to make the endothelial cell susceptible to malfunctioning and creating an AVM, that you actually need a second mutation on the other allele. And this is very recent evidence, and where we've used tissue from different organs in HHT patients and shown that you need a second, or in most AVMs, in telangiectasia, organ AVMs, there's a second mutation on the other allele, like a somatic mutation. So those areas where by chance, I assume by chance, a somatic mutation happened, then so you have those areas, a small percentage of cells or of vessels, and then there's an injury, either inflammation or a wound, some sort of angiogenic stimulus, and then you have this abnormal endothelial cell which doesn't have the brakes on and allows accelerated angiogenesis and development of an AVM. So that is my, okay, as I said, I gave my disclaimer first, my clinician's explanation of this. And the reason I went through all of this to you is, with you, even though it stresses me out talking about these things in a presentation, is because this has created an enormous number of targets for us. So we have targets now. Okay, I know I'm 1 minute and I'll be done. I just want to make sure I leave time for questions. We have targets now and therapies now looking at this whole pathway as well as this pathway. So there are targets that are agonist targets that are being developed. Let's say ALK1 agonist targets. There are AKT inhibitors that are being studied, mTOR inhibitors, anti-VEGF I've already started telling you about. So it's opened up a lot of new approaches to therapies in HHT, and bevacizumab, which is the anti-VEGF that is the first sort of, was our first observation that controlling a VEGF could have an impact in HHT, has really become an accepted treatment for patients with severe liver vascular malformations and severe bleeding. Within these early reports, a large proportion of patients who significantly improved. And these are not RCTs that I'm showing to you here, and I admit that freely, but this was what got us started thinking about the potential of these drugs. And we still use these drugs, and they are HHT or bevacizumab, I should say, is one of the HHT guidelines recommended therapies in very severe patients. And we have a number of patients who go from blood transfusion bleeding to no bleeding and no anemia on bevacizumab. Like it's quite dramatic. It's not a first-line therapy, but it's quite dramatic, dramatically impactful for severe patients. So this is this is just a list of some of the recent and ongoing clinical trials in HHT, which fit with what I was telling you. Some of our mechanistic targets are, and just to sort of briefly, and this is to give you hope that I'm showing you this list. And it gives me hope and everyone in HHT. Not only are we repurposing a bunch of drugs and testing those, but this was the first drug that was specifically developed for HHT, and there are a few more in the pipeline right now. And we're basically using nosebleeds as the window. So we're using nosebleeds as our clinical trial outcome because it's something we can measure, and it's due to small lesions, and we think that they're going to be more impacted by medical therapies. But that if we can learn from nosebleeds, from treating nosebleeds, if we can stop nosebleeds, then maybe we can eventually use this to prevent brain AVM bleeds, and maybe we'll get to reversing disease down the road as well. So far, a number of these therapies that have been in clinical trials have shown reduced epistaxis. As I said, this is just a quick summary through this to give you hope. And a number of these have become now tools, therapies that we're using in clinical practice in patients with difficult to manage disease. So to summarize, pulmonary AVMs, come back to where we started. Pulmonary AVMs can cause serious complications, and screening and treatment, preventative treatment, is recommended. Secondly, pulmonary AVMs most frequently happen in HHT, even though HHT often hasn't been recognized when someone is diagnosed with a pulmonary AVM. And then finally, HHT is a multi-organ disease, and it requires multidisciplinary care. They're advancing new therapies. There's a lot we can do. Specialized care in HHT centers is recommended in the international HHT guidelines, and I think it's where patients are most likely going to be able to follow the path they need to follow to get appropriate care for their lung AVMs and other symptoms of HHT. I'm going to stop there and say thank you very much. Happy to answer any questions. Whoops.
That was fantastic. Thank you. I'm just going to open this up in case someone types a question in the chat. So Josh.
Hi. Thank you so much.
Pleasure.
I share your trepidation about wading into molecular mechanisms and genetics.
I know, did I say anything really bad?
No.
Okay.
But I was curious about what you said about the idea of the somatic mutation. I always wonder in conditions like this, autosomal dominant, why is it that some people have mild disease, they have one AVM, they have AVM liver, and it seems like that defines mechanism, sort of theoretically one of the explanations. You know, in those patients, those very diffuse pulmonary disease, like, do they inherit two abnormal copies? Is there like a very early somatic mutation that's very widespread? Like, do we have a sense of what?
It's interesting. It doesn't seem to be compatible with life to inherit two HHT mutations. And so I think for many years, we also thought then that maybe simplistically thought that homozygosity or having two mutations was unlikely to be the explanation, but it's only been more recently that people have really pushed forward on this idea of loss of heterozygosity. So basically everyone with HHT or loss of function second mutation, everyone with HHT is born with one mutation. There have been some families where both parents, there's some places in the Dutch Antilles where both parents have HHT mutations, and the only children that are born are children with one mutation. So there's never been any evidence of someone carrying both. The diffuse patients, they seem to be mostly patients with endoglin mutation, which is, I didn't get into this, but endoglin, patients with patients with HHT and endoglin mutation have a higher risk of lung AVMs than patients with ALK1 mutation. So it makes sense that the diffuse are more endoglin, but we don't really know why. Like we don't know what else is, we don't know what's different about them. It's a great question. They're really a mystery that we need to unlock, both in terms of understanding why, but also how to help them. So far, the systemic therapies, at least like the anti-VEGF, in a small number of patients, people have given the anti-VEGF therapies to diffuse lung AVMs, doesn't seem to do anything at all. But there is some risk in those patients.
Thanks very much. Your one conversation looked up for 15 years.
Thank you.
Personal sacrifice with that probably too. It's such a wonderful questions. One you partially answered this. So if I understood correctly, this is actually a loss of function mutation, right? Not a loss of function somatic by any
Correct.
mutation.
Correct.
Okay.
Yes. So I'm sorry, I didn't say that clearly. Yes. So
The loss of function.
So people with an endoglin mutation have a 50% reduction in cell surface endoglin. I'm sorry, I didn't say that piece clearly. Same thing with ALK1 mutation. So they, yes.
So is there a predilection? So if you've got ALK mutation, you have more liver than.
Yeah, so there are some, there's overlap in all of them, but endoglin more associated with lung AVMs and brain AVMs, and ACVR1 mutation more associated with liver and GI. But everybody, any family with endoglin can have any manifestation in the same way. We don't have as much, we don't have a lot of good severity data, and we don't have a lot of good severity measures in HHT. That's sort of in development now, so I don't have an answer to that. But I can tell you that, life expectancy is close to normal in HHT, especially if you screen and treat for lung and brain AVMs, and you can prevent the early deaths. But there is a small reduction in life expectancy in adults with HHT, people that have survived to adulthood with HHT, and that's largely attributed to GI bleeding and liver vascular malformations. And so it makes sense that it's probably the ACVRL1 mutation patients that have a higher, that have a less good prognosis long term. The which ones? Yeah, great point. So we would always screen and treat the lung AVMs first before putting someone on almost any of the medical therapies for HHT. That's a great question, because sometimes patients come to us that are already on one of the therapies, standard kind of early therapies for bleeding is tranexamic acid, but we don't recommend that until the lung AVMs are treated, given that there might be an increased risk of them having a stroke. So in general, we say treat the lung AVMs first, characterize the disease first, and then embark on clinical therapies / clinical trials.
I don't understand the clinical therapies if it taxes the outcome.
Yes.
What is it that you treated the lung and then you're looking at the taxes of the outcome? Is that the best option?
Well, it's because we have epistaxis, we can measure it every single day, whereas lung AVMs change over about 20 years if they change at all. So they're very hard to, like one day, if we find a drug that if we have a drug that improves epistaxis and regresses the small lesions, the telangiectasia, then maybe we'll be in a position to say, hey, now it's time to consider long-term therapies to regress organ AVMs. But to us, that seems like a logical later step, So in the interim, we embolize, and it's a pretty good treatment.
Last question. You know a lot of these saline people, reports that I get on some patients who are investigating hypoxemia Parkinson's Christmas here. So.
Mhm.
there
It's a
is-
challenge, actually, the communication and the reporting back from cardiology about when we're looking for right to left shunt.
You get a typical study from your center?
So we, I would love to say everything's crystal clear. I would say that our problem is more that we have a lot of positive echoes, you know, so they'll call us and say, we just saw 1 or 2 bubbles go through. And so those are probably false positives, but in the context of HHT, where there's a very high pretest probability of lung AVMs, if we see even a very tiny shunt on bubble echo, we do the CT as our next step to make sure we don't miss something that needs embolization. But what's most important to me is that to feel confident with the negative result. And so I feel confident with that, with our echo lab, because they have so much experience and they completely understand what we're looking for. But sometimes patients get referred with an echo done in an outside lab and it's negative, and we do it and it's positive. And I think in part, the cardiology labs are just so used to looking for intracardiac shunt. And I know this sounds surprising, but it seems that sometimes they just stop looking after 3 cardiac cycles. They turn off the recording, you know, or they consider it not to be clinically important, so they don't report it. So sometimes we have to either go back and say, can you look again, or we just repeat the echo. So the negative predictive value of an echo done in a center that doesn't do this a lot, I think is a less clear cut, you know, but a positive echo, I think, should be followed up on of any degree.
Fantastic. I appreciate you taking the
Great.
time to answer questions,
Thank
and
you.
that was a
Pleasure.
fantastic talk. Thank you.
Thank you.